Mike Gibson, Katherine, Tuttle coming to you live from AHA 2024, and we're talking about the FLOW trial and looking at the kidney outcomes in people with cardiovascular risk. Tell us what you did and what you found.
Well, thanks, Mike. It's a pleasure to join you today and tell you a little bit more about the FLOW trial. This was a clinical trial conducted in people with type 2 diabetes and high or very high risk CKD. The primary outcome was a kidney outcome consisting of 50% or more GFR decline, kidney failure, dialysis or transplant, death due to kidney disease, or death due to cardiovascular disease. And we reported earlier this year that the results, of course, were highly favorable. The primary outcome was reduced by 24%. So what we are doing now at the AHA is reporting these results by cardiovascular risk status. So obviously, this group of people is very high risk for cardiovascular disease as well. More than 40% had established atherosclerotic CVD or heart failure at baseline. And so what we wanted to do was to report the results by prior CVD, and then among the patients who didn't have a history of CVD, we risk scored them by the new PREVENT score. And as you might imagine, 80% of the people, even without a prior history of CVD, were in a very high risk category, more than 20% at 10 years. So that's who was in the study. And what we report this time is the primary kidney outcome, the events, as well as rate of GFR decline and albuminuria. The bottom line is that across different strata of pre-existing CVD, whether MI, stroke, the combination of MI or stroke, PAD, or high PREVENT score, the results are entirely consistent, almost identical hazard ratios without any significant interactions according to those subgroups. With regard to rate of GFR decline, the reason we care about that is that's the pathway to kidney failure. And we know from an abundance of evidence from other trials is that if we slow GFR decline more than 0.7 mil per minute per 1.73 meters squared per year, and that's whether we do it by creatinine or cystatin C, it's highly predictive that the intervention will prevent clinical outcomes. So what we showed in FLOW is that that difference was actually nearly twice that, 1.2. And in some of the CVD subgroups, it was even closer to 1.4. So what we see is a highly significant benefit on preservation of function, which over time leads to less cases of not only kidney failure, but the GFR decline is highly associated with those cardiovascular events. And then finally, albuminuria was reduced by 40%. And again, across all subgroups, whether we looked at GFR decline or albuminuria, same results. I guess the main limitations would be these are subgroup analyses. They're pre-specified but not powered. The PREVENT analysis actually was post hoc because the PREVENT equation was only published about a year ago, long after we'd written the statistical analysis plan. So I want to disclose that, but very rigorous results. So at the end of the day, what we can say is this is a population of people, type 2 diabetes and CKD, who are very high risk for kidney as well as cardiovascular events. And with regard to preservation of kidney function and preventing adverse kidney outcomes, those results carry over into people who have established CVD or are very high risk. So for the cardiovascular clinician, that means your patients with type 2 diabetes and CKD are going to benefit from semaglutide, similar to other populations in terms of preserving kidney function, and also what we've already shown and reported, reducing MACE and heart failure events as well. So I'll stop there. I'm sure that's a lot all at once.
That was perfect. You know, we tend to think of all these as separate diseases. We're treating diabetes, we're treating the kidney, we're treating the heart, we're treating the brain, we're treating the peripheral artery disease, we're treating the liver, but they're all part of a syndrome, right,
Yep.
of obesity. And we keep talking about all these different outcomes, but they're all part of the same syndrome. So wonderful, wonderful work. Katherine, thanks for sharing with us. Keep up the great work. And thanks to all of you for joining us here live from AHA 2024.